Coming on to the contents, it consists of insight and various other parts of it, and the effect. It consists of psychoanalysis and how gave the concept, and the difference between the cognitive insight versus the clinical insight, and the factors influencing it. Coming on to the insight, it is the capacity of the patient to recognize that their mental symptoms are indicative of mental illness and they require a treatment. It is usually associated with impaired cognition, compliant to treatment, coercive treatment in the hospital, and admission as IPD patient. Freud psychoanalyzed with the insight. He referred to insight as a knowledge and understanding of one's unconscious mind. It usually signifies it as unconscious motivations of their behavior and degree of depth of understanding for the patient. McAvoy et al. In 1989 made a semi-structured questionnaire named ITAC, which is the Insight and Treatment Attitudes Questionnaire. And then Beck et al. In 2004 took a take on it, formed a Beck cognitive insight scale that measures the wider notions of the insights. In the measurement of insight, the scales consist of the Beck one consist of two subscales: self-reflectiveness and self-certainty. In K et al. In 1987 used the lack of insight and judgment item of the positive and negative syndrome scale used in schizophrenia as a single global measure of insights. To measure the insight in clinical practice, reliability and validity measure of the insight should be based on the factors influencing the insights that I have told before. In the factors influencing of insights. Comparative study of insight in neurosis and psychosis. Swanson et al. In 1995 found out that schizophrenic patients lack awareness about the illness, whereas the manic patients were aware about the illness but attributed it to a physical one. Studies have found out that schizoaffective and depressed patients have a more score on the insight. Etiology of insight, impaired insight, refusal to take prescribed medication, as I've told before, denying of illness at a psychological level, cognitive impairment. It is similar to anosognosia in the neurological conditions. Who don't know anosognosia, it refers to person's inability to recognize a neurological deficit occurring to himself. Usually it occurs after a stroke, where patient starts feeling like hemi-neglect is the term which I will use, where person feels that half of the body is not present, but he is not having the insight that half of the body is not there. Neural mechanisms like better insight is linked with greater response in inferior frontal gyrus, anterior insula, and the inferior parietal lobe. These are the neural mechanisms which lead to a better insight. For the assessment of insight in the clinical practice, we can use these. It is the patient aware of the phenomena that others have observed. Is the patient unusually active or related? If so, does the patient recognize the phenomena as abnormal? For example, maintaining that the unusual activity and cheerfulness are normal high spirits. If so, the doctors patient consider that they are caused by the mental illness. And does the patient think that he needs treatment? This is how we can assess the patient on a clinical basis. And now these are the grades of the insight. First grade is the complete denial of the illness. Slight awareness of being sick and needing help but denying it at the same time is the second grade. Third grade is awareness of being sick but blaming it on others, on external events, on medical or non-organic factors. And the fourth is intellectual insight, admission of illness and recognition that symptoms of failures in the social judgment are due to irrational feelings or disturbances without applying that the knowledge of to future experiences. Grade 5 is true emotional insight, emotional awareness of the motives and feelings of the underlying meaning of the symptoms, and whether this awareness leads to changes in personality and future behavior. Openness to new ideas and concepts about in self, impaired insight, diminished ability to understand the objective reality of situation. A person with very poor in recognition of acknowledgement is referred to as having poor insight or lack of insight. Anosognosia, as I have told before, it is the most extreme form where the patient has total absence of the insight into one's mental illness. These can be the questions which can be asked on a OPD basis, where when a person comes for the uh, conversation and we have the OPD history. Like we can use the questions: what brings you here today, and what seems to be the problem. These can be translated in the Hindi, and accordingly we can use them. A conclusion of the insight. Insight signifies a variety of ways in which a person's mental life approximates itself to the beliefs of others. That is, in terms of what constitutes an illness and what beliefs are abnormal and what medical advice it is reasonable to follow. Psychiatrists would assess and treat patients more accurately as well as enhance patients' adherence to treatment if they had an accurate understanding of insight. The concept of insight has stimulated research into difficult theoretical and practical areas such as self-awareness and treatment compliance, respectively. Coming on to the effect, first we need to remember the differences between the emotion versus the feeling. Like a feeling can be defined as a positive or negative reaction to some experience or event, and is the subjective experience of emotion. Emotion is a stirred up state caused by physiological changes occurring as a response to some event, and which tends to maintain or abolish the causative event. Affect, whereas is the meaning, short-lived emotion is defined as patient's present emotional responsiveness. Coming on to affect individually, it is a visible external objective manifestation of emotional state. Dynamic changes in the expressions of the emotional responses. Both internal or external stimuli can alter the effect. It is known as the emotional foreground, whereas mood, which we usually have, it is known as the emotional background. Describing the effect, effect can be evaluated along the following parameters. It has type, quality, range, variability, degree, intensity, stability, mobility, appropriateness, and congruence. Coming on to the type and quality of effect, type or quality is the predominant emotion expressed. There are six principal types of effect according to Ekman and Friesen. They took their take on this, the type and quality of the effect in 1971. They stated that happiness, sadness, fear, anxiety, shame, anger, or disgust are the main six principal types of effect. In range and variability, the degree to which the visible emotions vary. These are the range. The patient would be expected to display various types of affect, like smile, frown, appear interested, sad, or anxious. No standard degree of affect term is used. The patient showed an adequate range of affect can be used. These are usually narrow and restricted range can be seen. Expression of only one or two emotional states can be seen in example mania, schizoparanoid disorders, and obsessive compulsive disorders. Wide range of expanded range with several emotions are displayed in cluster B personality disorders, dementia, delirium, and intoxication or withdrawal. Coming on to the degree and intensity, low intensity effect can be seen in the usually are flattened, constricted, and restricted. Normal are usually get appropriate, responsive, and adequate, and high intensity are usually exaggerated, dramatic, and passionate. And coming on to a degree intensity continuation, it is the force of the expression, measure of the energy expended in conveying the feeling. Emotional expression is on the continuum. Intense effect may go with the narrow range, example mania or depression. Low intensity may go with the wide range, that is in the delirium. Coming on to the blunt, it is a lack of emotional sensitivity to other. And flattening is the limitation of usual intensity of the emotion, as seen in the schizophrenia, conversion, la belly indifference, and obsessive compulsive disorder. Heightened are seen in the mania, narcissistic, borderline personalities. Depressive patients usually convey intense distress or are muted or apathetic. Instability and reactivity of the effect, duration of an effective response, example as brief as facial expression or a tear shed, other may be more pervasive. During an interview, for example, there may be shifts anxiety at the beginning, sadness when discussing a loss, anger at the husband's infidelity, and happiness at the son's academic achievement. Their shifts may be for some movements and are appropriate to the context. If shifts in the facts are small and non-existent, are considered fixed or immobile and are more referable to the movement. Labile when these are rapid and frequent changes in the effect. Changes would be either in intensity or range. Example: happy, tearful, low irritations and high irritations, as in mania. Liability of effect is commonly seen in conditions like mania. Effect can vary very rapidly. Example from elated to irritable, expensive to hostile. Cluster B personality disorder. This is one of the defining aspects of the histrionic and borderline personalities. Delirium and dementia, intoxication with the drugs or alcohol, impulse control disorders. Inappropriate effect is seen in malingering. It is the emotional component of the patient's presentation that doesn't add up to the verbalized problems. In substance use, intoxication and withdrawal can lead to patients to be inappropriately jovial or unconcerned with the medical problems. In conversion disorder, la belle indifference is the term we usually associate with the conversion disorder. We describe a distinct lack of concern for the reported neurological deficits. Depression: when the patients have decided to attempted suicide, they can become unconcerned or untroubled by their pre-existing problems. Inappropriate effect is seen in delirious or demented states. Patient can seem to be unusually concerned about trivial matters. Antipsychotic use can lead to affective flattening, can occur through the Parkinsonian side effects of these medications. Coming to the congruence of the mood and effect. Mood effect may not be congruent to the effect cannot be congruent to the mood. Described by the incongruency may mean malingering. Two or more conditions like mood or personality disorders, substance use, schizoaffective disorders, schizophrenia, and psychotic mood disorders. Affect has basically three functions, which is self-perception, providing an emotional value, judgment, communications helps in expression of the feelings, and motivation. Affect is one of the key elements leading to the initiation of the action. These are my references.